The menstrual cycle is a clinical vital sign. It operates as a direct indicator of systemic health, reflecting the chemical precision of the hypothalamus, pituitary, ovarian axis. This dashboard illustrates parameters set by FIGO, the strict global standards defining normal menstruation. The first metric is frequency. A normal interval occurs between 24 and 38 days. The second metric is duration. Normal menstrual bleeding resolves in 8 days or less. Cycle regularity is defined by the length variation from 1 month to the next. For patients aged 26 to 41, an allowable variation is 7 days or less. For those younger or older, the acceptable window expands to 9 days. Volume is the final parameter. Research settings define heavy menstrual bleeding as blood loss exceeding 80 milliliters per cycle.
In clinical practice, the diagnosis relies on the patient's subjective experience, specifically whether the flow interferes with their physical, social, or emotional quality of life. When a patient's bleeding falls outside these specific frequency, duration, regularity, or volume metrics, it represents a failure within the underlying synchronized physiology. Generating a cycle that meets these exact FIGO criteria requires 2 distinct anatomical pathways operating simultaneously. This diagram maps the dual cycle structure. Top, the ovarian cycle's follicular, ovulation, and luteal phases. Bottom, the endometrial cycle's proliferative, secretory, and menstrual phases. The ovarian phases act as the primary driver, using chemical signals to force the endometrium through its stages. A structural defect in the uterus or a hormonal failure in the ovary breaks this synchronization, resulting in abnormal clinical presentations measured by FIGO criteria. This 3-tiered model represents the master network orchestrating phase 1 of the cycle, the hypothalamus pituitary ovarian, or HPO axis. The cascade starts at the top tier. The hypothalamus secretes gonadotropin-releasing hormone, or GnRH, in a highly regulated pulsatile rhythm. This GnRH reaches the anterior pituitary, commanding it to release 2 separate hormones into the bloodstream, follicle-stimulating hormone and luteinizing hormone. When follicle-stimulating hormone, or FSH, arrives at the ovary, it commands a cohort of primordial follicles to begin maturing. Inside each growing follicle, a 2-cell mechanism activates. Luteinizing hormone stimulates theca cells to synthesize androgens. FSH then drives the adjacent granulosa cells to aromatize those androgens into 17-beta-estradiol. As the follicles grow, they release this 17-beta-estradiol into systemic circulation. This initiates a negative feedback loop at the anterior pituitary, effectively shutting down the secretion of new FSH. With FSH levels dropping, the smaller follicles are starved and degenerate. Only one highly sensitive, dominant follicle manages to survive and continue growing. Concurrently, the circulating 17-beta-estradiol travels to the uterus, stimulating the basal layer of the endometrium to multiply and thicken. This initiates the proliferative phase. Phase 1 functions entirely on this negative feedback loop, utilizing diminishing hormones to select a single dominant follicle while building the initial physical architecture of the uterine lining. This line graph maps systemic estradiol levels. As the single dominant follicle rapidly matures, it secretes increasingly massive amounts of 17-beta-estradiol into the build stream. Eventually, that continuous secretion reaches a specific high concentration threshold. Hitting this threshold triggers a distinct physiological anomaly. Instead of acting as an inhibitor, 17-beta-estradiol abruptly flips its function. It becomes a positive feedback catalyst at the anterior pituitary. Subjected to this positive feedback, the pituitary unleashes a massive 10-fold surge of luteinizing hormone. This concentrated spike in LH degrades the structural integrity of the dominant follicle, physically forcing it to rupture open. Approximately 36 to 44 hours after the LH surge begins, the ruptured follicle releases its oocyte. This marks ovulation at day 14. This endocrinological feedback flip is the singular mandatory mechanical pivot required for a normal menstrual cycle to proceed. Immediately following ovulation, LH causes the remnants of the ruptured follicle to reorganize into a new glandular structure, the corpus luteum. The primary function of the corpus luteum is to synthesize and secrete massive volumes of progesterone.
This cross-section shows progesterone's effect on the uterus. It halts cellular proliferation and forces the tissue to mature. Complex glands develop, and twisted spiral arteries expand toward the surface to supply blood, marking the secretory phase. If a fertilized ovum does not implant, the corpus luteum has no signal to survive. It naturally regresses and dies off. The death of the corpus luteum causes systemic levels of both progesterone and estradiol to crash rapidly. The thick, highly vascularized endometrium relies entirely on these hormones for structural integrity. The abrupt withdrawal removes that support completely. The tissue destabilizes and sloughs off the uterine wall in a synchronized, orderly manner. This specific breakdown presents clinically as normal menses. By definition, normal menstruation is strictly a hormone withdrawal bleeding event, precisely orchestrated by the regression of the corpus luteum. When that sequence fails, the result is abnormal uterine bleeding. One of the primary disruptors of the cycle is ovulatory dysfunction, frequently seen in patients with polycystic ovary syndrome or at the extremes of reproductive age. In an anovulatory cycle, the dominant follicle fails to rupture. Because ovulation does not occur, a corpus luteum never forms. Without a corpus luteum, the ovary produces zero progesterone. This split screen compares normal tissue on the left to an anovulatory state on the right. Without progesterone to halt proliferation and mature the glands, the estrogen from phase 1 continues stimulating the endometrium entirely unopposed. The result is chaotic, uneven overgrowth. The proliferating tissue eventually outstrips its own blood supply. Without the structural stability of progesterone, the fragile vascular network physically collapses under its own weight. This disorganized breakdown creates unpredictable, irregular, and often heavily symptomatic bleeding. Anovulatory bleeding is a failure of endocrinological synchrony. The absence of a coordinated progesterone withdrawal leaves the tissue to break down randomly through structural chaos. To classify the etiologies of abnormal uterine bleeding, Figo established the Palm-Cohen framework, dividing causes into structural and non-structural categories. The left side defines structural causes under the acronym PALM: polyps, adenomyosis, leiomyomas, and malignancy or hyperplasia. The right side categorizes non-structural issues: coagulopathy, ovulatory dysfunction, endometrial dysfunction, iatrogenic factors, and conditions not otherwise classified. Clinicians rely on a strict diagnostic sequence to navigate this chart. The process begins with basic laboratory studies to screen for non-structural drivers, such as endocrine abnormalities or coagulopathies. The second step is a pelvic ultrasound. This serves as the primary imaging modality to identify the physical structural defects listed in the PALM categories. In specific cases, the final step is endometrial tissue sampling, utilized to definitively rule out cellular hyperplasia or malignancy. By understanding the physiological pathways of the HPO axis and rigorously applying the Palm-Cohen criteria, a clinician can isolate a patient's abnormal bleeding parameters and trace them back to their exact anatomical or hormonal origin.